We are live.
Muted. Prashant, you're muted.
Prashant sir, you are muted.
So we are live.
Yeah. Good evening, postgraduates, and welcome to this 83rd episode of All India Postgraduate Teaching Program, which is an initiative from ARC AIOS. The new batches of postgraduates have joined their respective institute, and it is time for you to look for and decide what topic you are going to have for your thesis, and your mentors or your postgraduate teachers must have allotted you the same and must have given you the task to find it out. With the same intention, ARC team decided that we should have a comprehensive guide for postgraduate thesis writing. And I'm really extremely thankful to Dr. Deepak Mishra and Dr. Rajiv Raman for helping us out in charting out this particular program for the month of February, which has 4 episodes. And it is very aptly labeled as Navigating the Path to a Successful Thesis. We hope this particular 4 episodes will be as a ready reckoner for you at any point of time, and it would be available for you on the AIOS archives. The first episode was about the understanding the basis of thesis work. The second one on the last Wednesday was how to choose and refine your topic. And today is the third session where we are talking about research design and methodology. Today's topics would be further details would be given by Dr. Deepak Mishra. I'm really thankful to speakers, Dr. Santosh Honavar, who is the Director of Medical Services at Center for Sight, Hyderabad, Dr. Professor Vanati, who is a Professor of Cornea, Cataract and Refractive Services at RP Center, AIIMS, New Delhi, Dr. Ravni George, who is a Consultant Glaucoma Services at Shankar Nethralaya, Chennai, and Dr. Alok Sen, who is Head Medical Superintendent and HOD Vitreoretina and uveitis at Sadguru Netra Chikitsalaya, Chitrakoot. My special thanks also goes to all the senior faculties who are as a discussant, Dr. Sandeep Saxena, who is Senior Professor and Chief of Retina Services at KGMU, Lucknow, Professor Radhika Tandon, who is the Head and Professor at RP Center, AIIMS, New Delhi, Dr. Sumit Khanduja, who is a faculty and head of the department at Kalpana Chawla Government Medical College and Hospital, Karnal, and Dr. Anubharati, who is a faculty at Shantilal Sangvi Cornea Institute and head of Cataract and Refractive Services at LVPI, Hyderabad. I'm extremely thankful to all the senior faculties for sparing their valuable time for this postgraduate event. Now I request Dr. Deepak Mishra to take over the proceedings further.
Thank you, sir. In continuation of today's meeting, the most important thing for any research is to have or how to formulate a research question. And for this important topic, we have our own teacher and a researcher at par with wonderful experience and lot of research questions and teaching experiences with the research projects. I request Dr. Santosh Honavar sir to please take this topic and gives us few important tips how to formulate a research question. Santosh sir, please.
Thank you, Deepak. Thank you, Prashant, for this wonderful initiative. I'm sure it will be very useful for postgraduate students and for fellows alike, because some of the institutes do have fellowship project as well. Is my screen seen? Yeah. Okay, I was asked to speak on how to formulate a research question. And I have not spoken on this topic before, so these are some of the new slides that I had to make. So excuse me if there are any deficiencies, and panelists, of course, can add on to what I say. There should be no mismatch in research. Almost always mismatch is considered fashionable, but in research, there is no such fashion. And finding the right match is very important as far as research is concerned. The right beginning is formulation of a research question. And it's like the first few alphabets of any language that you learn. What then is a research question? A research question is the uncertainty that the investigator wants to resolve by performing the study, or the scientific question that he wants to answer in a particular study. For a postgraduate student, when he or she does a thesis, then this becomes slightly tricky. it may sometimes be very difficult to ideate a research question, but then there are no dearth of research questions at all. It said that when love is pure, each heartbeat becomes a song. When the focus is on research with a purpose, ideas can come pouring. It's also said that research is formalized curiosity. It's poking and prying with a purpose. And when you do that in your day-to-day practice, you'll have plenty of research questions. To develop a research question, first you must begin with some research interest. Here, egg does come first. Then where lies the challenge? The challenge is finding an important research question that can be transformed into a feasible and a valid study plan. And for a postgraduate student, I should add that this has to be done in the given time and with given sparse resources with limited understanding of the issue in question. As we were discussing at the beginning of this webinar, even before we went online, postgraduate students are asked to submit their research topic within a few months after they join. In some institutes in the first month itself, or at least in the first 3 months or 6 months, by which time they're not fully conversant with what ophthalmology has to offer. They may have had rotation in one of the units, maybe a cataract unit, maybe a cornea unit, and they would not have had an occasion to go through the beautiful spectrum of ophthalmology. And they would not be understanding the intricacies of ophthalmology for sure at that point in time. For a consummate researcher, the origin of a research question is natural. If we have already a focus on a particular area of interest, for me, if it is retinoblastoma, then I have plenty of research questions. But for a novice, a resident, this is a very difficult process. What he or she can do is they could go through some of the recent literature and understand or find out what sort of studies have stimulated their interest when they have read them in a journal, or if they have attended a conference, what sort of presentations have attracted them. Or perhaps if they were bothered by a specific patient whose treatment seemed inadequate, and what could have been done differently that may have mitigated the problem or improved the outcome. Or if one of your seniors asked you that you must suture a small laceration and the other said that you should leave it alone just as dogmatically, means that you have been kind of encountering totally diametric points of view about a common problem. This is a mnemonic order to understand what interests you in terms of research. Observe the surroundings. That means that you should keep your eyes and ears open in your clinic as well as in the operating theater. Read the literature. Please make a beginning by reading some of the top journals or journals that are relevant to India, such as Indian Journal of Ophthalmology. Discuss with the mentors. It could be anybody. It may not be the senior most mentor finally who is destined to be a guide. You could even discuss with your seniors or senior residents, but do discuss. Very grossly evaluate the feasibility of it being done in your own medical college or your postgraduate institute. Does it support that kind of a research that you're envisioning? And do we have the resources to perform such a study? Then comes T, that is technology. If you try to incorporate newer advances, you might change the research paradigm. For example, if your institute or your medical college has acquired a new gadget which has not been really worked on well for a particular condition, or an old, relatively old gadget, but applicability of that to a newer disease concept. Think about whether your research project is sellable. Sellable in the sense not financially, but can you present it in a conference? Can you submit it as an abstract in an international conference, and perhaps it will be selected? Can you publish it in a good journal? And being a novel concept, can it win an award? Such sort of stuff. Or think, or at least ponder over if you have the audacity to challenge a particular dogma. If you're a skeptic, perhaps you can become one of the best researchers. There was a wound suturing study. There was a resident in an emergency care situation who was posted there. And every day he was suturing about 20 lacerations anywhere in the body. He was a general surgery resident. Now, he came to the conclusion that if you suture or not suture, it really does not matter, because he had seen some old wounds which had healed beautifully well, and the patient had come for some other problem to the emergency. Now, to challenge this dogma and to do a study and prove it, he had to be very brave, because he was classically taught, and we are also classically taught, that any wound needs to be sutured. So he planned a study where he compared not suturing a 2 centimeter wound, just washing it with tap water and leaving it alone in an uncritical area such as hand or leg, not the face, of course, or the back, and suturing a 2 centimeter wound. Does it make a difference in ultimate healing and the cosmesis? And they found out that it did not make a difference at all. Now it's become a standard of care in many centers not to suture a small wound unless it is cosmetically or functionally concerning. Then add finer to it. Well, T is fine, but the finer, this is the criteria. Your research question should be feasible, it should be interesting, novel, ethical, and relevant. Feasible in terms of adequate number of subjects should be available. If you're talking about doing a project on keratoconus, that means that for the question to be answered adequately and the study to have the power to answer that question reliably well, you should have adequate number of subjects of keratoconus that should be available. They should undergo adequate duration of follow-up. They should undergo the intervention that has been planned. And the institute or the medical college should have adequate technical expertise and the gadgetry to evaluate this condition and do this intervention. And also, what about money and support? Would it be given by your institute or the medical college? Would a grant be accessible to you? Is the scope of the study manageable in the time that is given? Will there be any funding at all to carry out the study? Is it interesting? Even Vada Pav has 10 interesting facts. So your research study or the study question should be interesting enough. Novel, PRIC is the acronym here. Provide new finding, refutes previous finding, innovation in practice pattern. At least it should change the way the particular disease or an entity is managed in your own setting or in your own region. Ideally, it should be conceptually new and provide for knowledge advancement. Ethics, of course, should never be ignored. Ethics is not a transient line on sand. It's an indelible Lakshman Rekha which should be respected deeply and critically. And of course, your project should be able to pass through the respective the boards that you have for evaluation. It should be relevant to the population and the region in question, in the sense that whatever topic that you take up should be at least relevant to the country that you live in and the region that you practice in. It should likely to have significant impact on the clinical practice, scientific knowledge, or the health policy, and may influence direction for future research. So it should fit in to the scheme, and it should produce usable knowledge. MAPS is another. Manageable, appropriate. It should be of potential value in terms of presentation, publication, and prizes at least. And it should be systematic. Now what? You have a research question in hand, but how do you progress further? While finer are the criteria to kind of come to a research question, PICO is the process through which you have to pass it before it becomes an idea. PICO or PICO-T, extended PICO, includes population, intervention, comparison, outcome, and time. This format helps to structure the question as well as refine and narrow the focus. To put it simply, population in terms of patients, age, gender, location, and characteristic. Intervention, what is the treatment that you are envisaging to undertake? Is it a surgery or exposure to a particular drug? Comparison, how does that intervention compare to other treatments? Are you going to study that? What specific outcomes are you going to accomplish, primary as well as secondary? So at the end of post-PICO processing, you have a hypothesis, which is an educated prediction of the expected outcome based on the existing knowledge and assumptions, and also a null hypothesis. So let's just take the example of thyroid eye disease here. So we were trying to study the role of teprotumumab, which is a new drug, in active thyroid eye disease. So here the research question can be, can teprotumumab be used as a primary therapy, and is it effective in controlling active thyroid eye disease? So population here is a group of patients who have active thyroid eye disease, which means that they should have spontaneous pain, pain on movement, redness of the eyelid, conjunctiva, swelling of the eyelid, and swelling of the conjunctiva. Exposure here is injection teprotumumab, which is protocol-based injection of teprotumumab for a particular duration of time. And what do you compare that group with? With patients who are receiving the current standard of care, which is intravenous methylprednisolone, again, protocol-based IVMP treatment. And the outcome would be remission from activity. Now, the factors that you measure in outcome would be duration to remission. After how many months of use of teprotumumab has the patient remitted from activity? What is the duration of remission? For how long does the patient stay in remission? What is the residual functional deficit? That does the patient have less of diplopia, less of need for, say, orbital decompression, less of eyelid retraction, etc. So hypothesis here would be primary treatment with teprotumumab will be effective in controlling disease activity in TED and in providing remission. And the null hypothesis naturally would be primary treatment with this particular drug will not be more effective than the current standard of care, which is IVMP, in controlling activity in thyroid eye disease. It's like working backwards. You start with an area of interest and gain working knowledge on the topic by doing relevant research on the literature, formulate working questions, problematization, gap spotting, etc. Then arrive at a relevant research questions. Now, what are the types of research questions that you have? These are divided into 8 types. Existence. For example, if you're looking at, say, intraoperative meiosis in a patient with undergoing cataract surgery, you may want to question if the dogma whether iris has proprioception or not. Description and classification. What are the types of intraoperative meiosis is that particular question. If you have to go into question the composition, at what stage of cataract surgery does intraoperative meiosis occur? That could be a study question. If you want to study the relationship, then you look for association between types of anesthesia, peribulbar versus topical, type of viscoelastic, phacopower, phacotime on intraoperative meiosis. If you want to look at descriptive comparative, then you look at intraoperative meiosis in topical anesthesia cataract surgery versus peribulbar block. Causality, then does pre-existing glaucoma cause intraoperative meiosis? Causality comparative, then you bring in tinglactate versus PSS, intraoperative meiosis, the relationship. Causality comparative interaction, then the same question in patients with or without pre-existing glaucoma. So finally, I would say that the research question is the pivots to a study. Time needs to be invested in formulating an appropriate research question, keeping in mind the multitude of factors which a resident is going to face, especially at the beginning of career, and the problem that he or she would face if the project is not completed at an appropriate time and the thesis is not written at an appropriate time. But while you are at it, make it the best. Thank you so much. Any questions? I'm happy to answer. Moderator has disappeared.
Hello, Sandeep Saxena, sir.
Yeah. We'll be
Sir,
having a question and answer session at the end, or do you want to do it after every?
Sir, just one question. What are according to you, what are the characteristics of a good research question for the PG candidates?
I think for me, the first and foremost will be that since we have a lot of patients at all the center or the medical colleges, The first will be that the feasibility, because every institution has a different set or different level of instrumentation and all those things. So my first priority is that whatever research question I am planning, whether it will be feasible in my kind of setup or not. And then the second will be that what is novel part in the question, and as Dr. Santosh very rightly pointed out, all the facts that how in a sort of a reverse triangle format you can just then zoom in into your research. So I think feasibility part is the first, and I think which the mentor has to decide that whether this can be done or not. And then, as Dr. Santosh was saying earlier, that a sort of a concurrence has to be drawn with the student, whether he will be able to go along the research with that kind of a research question. Okay.
Thank you, sir. So our next talk is after knowing how to formulate a research question, means which design we choose to conduct our study or how we plan our design. So our next talk by Professor Manathi ma'am on the design selection, means how we plan our research. Ma'am, please.
Thank you, Deepak. Am I audible?
Yes, ma'am. You are
Yeah,
audible and
yeah. Okay. So I think that was a lively talk by Dr. Honavar, making the research question formulation simple for postgraduates to understand. So the next 8 to 10 minutes, I will speak to you on study design selection. This is a very important topic here, and I'm going to make it easy to understand, or I'm going to simplify it, catering to postgraduate study designs only. So I'm not going to make it very complicated here, so that it is easy for the postgraduates to understand here. So the first question is, why do we actually need to do a research at all? Why is research part of the study curriculum of a postgraduate here? So it's there to make them understand that research is a systematized effort to gain new knowledge. So that's part of the curriculum of any postgraduate study, and hence they need to know how to conduct research in its right methodology and in the right way and the right perspective here. So the steps in research is, first, of course, it's review of literature. And then once you've reviewed all the literature on a particular subject which you are going to research about, then you identify the lacunae in knowledge, meaning what aspect of that particular subject is still not being described, or there is something which you need to understand further in that particular subject here. Once this is done, then this becomes the aim and objective of the research you're going to be doing here. So there comes the methodology plan, so that the methodology is devised such that it adopts the best study design which can address the aim and objective which you have framed here, which means the methodology adopts the correct study design to address the research question which has been formulated for your particular study. Hence, you need to know the type of study designs which are there so that you would actually choose the correct study design. And please remember, after the entire study is done and once it's gone into the writing stage after completion, and then when you find that the study methodology is wrong, a flawed studied methodology will not take your manuscript through to publication. So that will become point number 1 for a rejection. Hence, you have to place a lot of importance on choosing the right methodology and incorporating the right study design which will be apt for your study question. So I will come to that during the course of my talk, and then it is how you execute your study. And once you've completed your study, how you compile your data, you classify, categorize your data, and how you're presenting your data for analysis. Then it is statistical analysis itself, Then the tests, the statistical tests of significance, which have to be performed according to the appropriate tests which need to be applied here. What are the inferences you gain from these statistical analysis here? Then you go down to write down your report or write down your research work. And then is the last phase of you disseminate your research, meaning you are sharing the results of your research with your target audience so that others will also benefit from what you have found out in your study. So this is how a step of the research needs to be here. What do you actually mean by a study design here? Study design is a specific protocol by which you can conduct a study, and this enables the researcher or the investigator to translate the research conceptual hypothesis or the research hypothesis into one which is operational or which can be carried out here. So that is what a study design or a study pattern does here. And frankly, when you start a study design, it looks all very blurred. So for postgraduates, I will tell you, don't get scared. It's not a new subject, and all of us have studied community medicine. And this is a very dry part of community medicine, which many of us choose to ignore when we are taking the subject. So go back to your community medicine books and just open up the chapter and revise it once, and then you would find it all comes back to you, and it's easier for you to understand and apply it to the research which you are going to be doing here. That would probably be step number 1 when you're starting on your study design here. So now let's go through this particular flow chart to make you understand the study design, how it has to be chosen here. So how do you go about your decision making on choosing the right study design? So your study would have defined a particular intervention which it's going to be done here. So are you going to do an intervention, or you're not doing an intervention and you're just observing the results of a particular event which you're looking at here? So in the event that you are not going to have an intervention, it's only an observation, no intervention, then it's an observational study. If you're going to do an intervention, then it becomes an experimental study or a clinical study here. So here, for practical purposes of this talk, the experimental almost is sort of used as clinical study, okay? So you would either do an observational study or you're going to do a clinical study if you're doing an intervention here. So let's move to, if you're just going to do an observational study, are you planning to have a comparison group? Are you going to observe data of 2 groups? So the answer can again be whether it's yes or whether it is no. If you're not having a comparison, you're only going to study one group, then one particular sample, then it becomes a descriptive study here. Suppose you're going to compare one group with another group and you're going to observe their data, then it becomes an analytical observational study here. In an analytical study, it can again be categorized into 3 principal types. It could be a cohort study, could be a cross-sectional study, or it could be a case-control study here. So we'll learn more about this as we are going down, but that's what you need to understand, whether your study will fall. Principally, most of your studies will fall into these 3 categories here. And you would want to know whether you're doing a study cohort, and cohort studies are longitudinal studies. So you should understand what you mean by longitudinal studies and what you mean by cross-sectional studies. Longitudinal study, you study the outcome at different points of time, which are usually serial or consecutive. Cross-sectional, you're studying the event and the outcome at one particular point of time. And it's a case control study where the outcome has already occurred and you're taking it backwards. So it's always a retrospective study. So that's a case control study here. So these are primarily the 3 designs here. And let's move on to the clinical study, the experimental study. So when you are doing a clinical study, where you're particularly studying an intervention, you're doing a surgery, you're giving a medication, or you're doing a particular procedure or a surgical technique here. In that case, then if you are probably studying it in 2 groups, and how are you assigning your patients or your subjects into 2 groups? If you're particularly following a randomization, then it's called a randomized clinical trial here. If you're not following a randomization, and it's a non-randomized clinical trial here. So this is how you would go about, or the basic study designs which exist. And you would probably choose the one which suits best for your particular research question. Again, depending upon randomization, it becomes a randomized or a non-randomized study. Depending upon whether you're blinding the study, which means the observer only is blinded, it's a single blinded study. You have a double blinded study, then these are mostly for pharmaceutical or for therapeutic interventions here. When you're using a particular medication here, the investigator also does not know, and the drug prescription also does not know, and the code is broken at the end of the study, and that's a double blinded study here. Again, depending on a study design itself, it could be a simple randomized study or it could be a crossover study. These can be a little more complex, but when you are probably comparing two treatment methodologies, these will become a good study, but it is more time consuming and you would have to define your interventions and your study treatment plans more meticulously in such studies here. Depending upon the area whether the study is going to be done, it could be a field study, it could be a clinical study, or it could be a laboratory study here. So this is how you probably describe your various studies here. Again, going back to understand the direction of the study here. So whether it's going to be a prospective study, whether it's going to be a retrospective study, whether it could be a ambispective study, which means you'll probably include both retrospective and prospective data in your particular study design here. And these are particular aspects which you will need to understand here. So if it's a prospective, if a particular group, the study population is exposed to a particular event here and you're studying the outcome which is happening in future here, that becomes a prospective study. A retrospective study is you're choosing a particular group which has already undergone the exposure, and then you are just going back in time to see what happened after this is. So that's a retrospective study here. So that's how the direction of the study goes on. This is a simple diagrammatic representation which you could probably remember. And always remember, your cohort studies are usually longitudinal studies and they are prospective always. A case control study is usually a retrospective study here, and your cross-sectional study is a single point study here. So you would probably do population-based studies where you particularly will look at an entire particular population for a particular event which has occurred because of you look at the outcome which has happened because of a particular event here. So this is how you would define your studies here. So observational studies, the commonest descriptive studies which are very easy to do are the case reports, the case series, and the population studies here. So the case report is the lowest rung in the ladder here. And it's very simple. It's very easy to do. It's just a simple descriptive study of one particular case where you've probably done a new interventional procedure, a new surgical technique, you've used a new medication here. And such studies help you to formulate a hypothesis here. So they are usually hypothesis formulating ones where you're probably looking at and saying, does this drug work in this patient? Does this technique work in this patient? Does this innovation really help out? So that's when you just do a single case descriptive study here. And you could probably study a series of cases which underwent that particular procedure. Then it becomes a case series here. And analytical studies where you're analyzing the data which you have observed. It could be, again, cross-sectional, case control, or a cohort study here. If you're looking at an intervention, then it's an experimental clinical or a clinical study with randomization or non-randomization here. So descriptive studies as case series I already mentioned. They are usually hypothesis generating. They are very easy to perform. These are short-term studies here, and they are usually selected. The only downside of this is there is a bias to the case selection because the investigator recruits the cases. So usually when you look at the level of evidence which these studies provide, you would probably take it with a word of caution, because if I'm choosing a study, if I'm the investigator, I could probably choose cases which are going to give me better outcomes here. So there's always a selection bias here. So that would probably mar, or that would probably affect the outcome or the way you're going to interpret these results of case series here. And again, they do not have any control, so you do not know what would happen in a different scenario in the same procedure, the same intervention is particularly studied here. In a cross-sectional study, again, the data collection is only at a single point of time where you want to just find out an association here. For example, you take a population here, and in that population, you want to study what is the particular disease, what is the what number or what percentage of the population has a particular disease, and what percentage of the population does not have the disease. And both these groups are exposed to the factor and not exposed. So these are two categories or criteria which are evaluated in that particular population which is being studied. And a cross-sectional study is largely useful for studying prevalence. So when you want to evaluate prevalence, a cross-sectional study is what is most important here. And again, you could have population-based cross-sectional studies, or you could have hospital-based cross-sectional studies. Depending upon the field or the area where you're choosing to do your study, the interpretation of your results will also be different here, and your sample sizing will vary accordingly as well here. So in cross-sectional studies, for example, you will look at a general population which is doing meditation and which is not doing meditation, and how does this affect the diabetes mellitus prevalence in this particular study population. So that's a simple study question here. And if you're seeing that people, if you do meditation, is diabetes less in them? And those who are not doing medication, is the diabetes or blood sugar control not as good in this picture? That's a cross-sectional study where you're looking at both the event and outcome at a single time point here. So that's an example of a cross-sectional study. It's very quick to do. It's cheap. It's not expensive to do these studies here. But the downside is it cannot relate the cause and the effect here. So that's something which you cannot infer from doing cross-sectional studies here. When you look at a case control study here, so your cases are cases with a particular disease. For example, it's a group of patients who are having glaucoma here. And your control will be group of patients who are not having glaucoma. But both these groups are exposed to the particular event which you are analyzing here. So for example, you're looking at those with glaucoma who do meditation and who do not do meditation, and those without glaucoma who again do meditation and do not do meditation, and you're trying to find out, does meditation really affect the way intraocular pressure is being affected, and what's the effect of meditation on intraocular pressure here? So this is an example of a case control study where you're evaluating something which is retrospective here. So that's again very quick, very easy to do. It can provide you tests of significance such as the odds ratio here. It can be used for studying some rare outcomes here. Can evaluate the relationship of the exposure to disease, but then it's only a single point study or a single outcome analysis study here. So that's the downside of it here. And it is again susceptible to a high amount of bias here. So these are all the downsides when you do a case control study as well. A cohort study is a much better study here, where a cohort is a study sample which is particularly exposed to one particular event which you are evaluating, or one particular intervention which you are evaluating here. And you would see whether that particular group is exposed to the treatment or not exposed to the particular outcome. And you would record what happened after that intervention has been done. And you would probably compare the two cohorts here, or you could have a single cohort study. And this would be useful for taking out tests of significance such as relative risk, attributed risk, risk ratios here. And you would be able to study multiple outcomes when you adopt this study design here. And it can help you to adjust for many confounding variables. It's an expensive study here. It's time consuming here. It's usually longitudinal and prospective. So these are actually longer study groups, a longer time period here. And your sample calculation also needs to be effective in these cases here. So this is how you can apply your tests of significance here. If you've done a cohort study, then your significance testing, relative risk, attributable risk, odds ratios can be calculated, whereas on a case control, you could probably just do only tests of significance, and you can do only odds ratios here. This is looking in a nutshell at as an overview of how the clinical trials can be done, and how clinical trials can be randomized, and how they are non-randomized if you're not particularly following any particular pattern of randomization. Again, in randomization, it can be more complex as concurrent parallel randomization. sequential randomization, randomization with external design. So I'm going to leave this as more advanced aspects here, but just remember there is a randomization pattern which you could probably look at now. It's all available online as well, or the person who helps you with your biostatistics can help you how to go about your randomization in these cases here. If you can't randomize, then it becomes a non-randomized study here, but then you also have an element of bias here when you're doing a non-randomized study here. Simple randomizations, crossover randomizations, again, are more complex study designs here. They could again be single-blinded and double-blinded, as I told you. And an example of that is, for example, if I am studying the role of biological tear replacements in a dry eye disease here, I'm giving a placebo and I'm using a particular medication here. So I do not know which group has received what medication. So I'm the investigator, and I'm looking at the result of these patients when they've used it for 3 months period, and then they come to me, but I do not know what medication has been given. And that's recorded by the person who's recruiting the patients into the study cohorts here. It's double-blinded when the patient who's recruiting and the patient who's observing, both of them, person who's observing, do not know what the particular medication is. It is coded here, and the code is broken once the entire study is completed here. So that's a double-blinded study. I've already told you what a field study is, what a laboratory-based study is, and what a clinical trial is here. Clinical trials can be single centers, can be multiple centers as well here. So again, a quick run through study designs. One is just you could have cases and you can have controls here. And clinical trials largely are randomized studies, which could be single center or multi-centers here. The other type of interventional study is when you have two comparative groups here, two comparative cohorts, which are looking at two different interventions, and they are comparing the two different interventions for the same particular disease here. The crossover study design is again the sample which is divided into or categorized into two groups, which is studying two different interventions, and after the outcome is done and a washout period, the groups are crossed over and the interventions are again repeated here. So the same group undergoes both the interventional modalities, and you see what is the response you are getting when the two interventional modalities are being subjected to the same group here. Quasi-experimental studies is here when no particular randomization pattern is followed here. So that's a quasi. Block experimentals here, when your study groups are in blocks here, and there is a block randomization for your studies here. So just in conclusion, as we are coming close, your steps, remember, write down your protocol. So that's what you need to know with your, you sit with your research, with your mentor, with your thesis guide, and you draw up a protocol. So which means a research question is made, and you would see what is going to be your study sample and which research methodology is the study design is the best to be adopted to address that particular research question here. The reference population and the study population is carefully defined and chosen here. Once you have chosen your study population, your statistician helps you to calculate the sample or the study sample size of the study sample, and the sample size needs to be calculated. You will have to carefully go through those you will include and those you will exclude. It's very important to define your study recruits here, and then you would decide what type of randomization you need to do for your particular study design here. Do you need to have a control group? Do you have to have a comparison group if you're comparing two treatments here, or you're comparing one particular intervention in the group, in the disease, and you're looking at the disease without the particular interventions here? And then you will define whether you need to make it a cross-sectional or you're going to make it a longitudinal study group here. And then what are the follow-up data and what are the study parameters which you need to be recording at baseline, at recruitment, and during follow-ups if you're having a longitudinal cohort study, and how you're going to be assessing the outcomes and what are the statistical tests you will be applying for this particular research question here. So a simple example for you is if your type of question is talking about evaluating what is the burden of a particular disease which you need to, if, for example, you're looking at a prevalence of a disease and incidence of a disease, then you will look at study designs which could be field surveys, cross-sectional surveys, or longitudinal surveys. If you want to look at the cost risk effects, you're looking at the prognosis of a particular intervention, then your case control studies, cohort studies, and randomization studies are best suited for those. If you're looking at treatment efficacies, randomized control trials will be the best one. You also have what is known as diagnostic study designs here. You have correlational study designs also. They're again more advanced, so I've intentionally left those out for you. And those are when you're looking at higher research, writing protocols for larger grants, you're probably going to be evaluating those kind of studies, and you're looking at a cost effectiveness of a particular procedure. Then again, you can use a randomized control trial here. So this is going to be the last one, and this is about the hierarchy. And when you could just see the lowest down the line is a case report, and the highest is a randomized control study. The evidence level or the effect of bias is the least when you're doing an RCT here. So I think I will stop here. You'll understand more of this if you start reading more of your more studies here. And that would help you to understand how you could probably incorporate your study designs for the best study design for the best research question. Thank you.
Thank you, ma'am, for such an illustrative talk, and you have summarized each and every point. Before I went to invite our next speaker, Professor Radhika Tandon, ma'am, you have huge experience for guiding lot of PGs and mentors. Ma'am, what is your view? Means which type of study you suggest for a PG? Means duration is short for the anywhere in the PG it is 3 years. So which type of study design they can choose for their betterment, or so that they can finish it on time, as per your point of view?
Yes, so thank you, Deepak. Firstly, thank you, Vanity, for so nicely covering the topic in a very simple yet detailed manner. What I would say in simple words is that there's no one single kind of a study design which one can universally recommend will be best for a thesis. But as Dr. Sandeep had mentioned before me, and then if you amalgamate Santosh's lecture as well as Vanity's lecture, you have to start from a point where you first, the PG student needs to have some idea. I don't like the thing of completely spoon feeding the PG student. So usually if you're allotted a thesis candidate, you have a little discussion with them that broadly, firstly, what kind of area of ophthalmology would you like to work in? So usually they'll come and take their topic after a month of exposure. Some of them will have no idea, but some of them will tell you, okay, I want to work in cataract, I want to work in cornea. So give them first the encouragement to think for themselves and choose. Then when you go there, you say, all right, and you have to have some ideas of your own, and then you tell them that these are the various topics, and you just see if you want to look at any particular aspect of it, and you take into consideration that it should be novel, it should be worth studying, it should be clinically relevant, etc. Once you narrow it down to some kind of an area, like supposing they have taken glaucoma and they are worried about, say, medical management of primary open-angle glaucoma, then you will, they may be wanting to compare two drugs, etc. Then coming to your specific question now as to what is practical during a thesis duration. If you really see, given the 3 years duration, the actual data collection part is they practically have only 1 year. So if you're doing any intervention, then you must keep the limitation of the follow-up. 6 months can sometimes really be difficult. So minimum 3 months follow-up, and you can say 6 months if possible. So give yourself that kind of a follow-up if it's going to be a prospective study and it's going to be a outcome of an intervention. If it's a retrospective study or an ambispective study, it gives them a little bit of more flexibility that they can increase their sample size, and you can, have ambispective becomes much easier. However, there are some times when a person really wants to do something really novel. It may be a new surgical technique also. Then you can call it a pilot clinical trial where you will limit the number of cases. It may be pilot studies, usually 10, 15, 20 cases are also fine. And then you will see the duration. So in a nutshell, I would say RCTs can be a little difficult in a thesis. So you really have to think carefully, because if you have an RCT, there's a very rigorous method of sample size calculation, etc. So you could call it a pilot clinical trial. Retrospective studies are extremely simple generally, and therefore one could do ambispective, because retrospective have a flaw that many things that you would want to study, you may not have the data. So if you combine it as some prospective cases as well as retrospective cases, that's ambispective, you can get a more useful outcome of that. So I think that is it. Things like long cohorts and case control studies become more challenging, but everything is possible if it is well designed and if the person understands it and works hard at it right from the beginning. And often, the students have a tendency to waste time unnecessarily, or maybe not their fault, but they have to keep a timeline. So they've been given the thesis topic. They usually have to submit it within 4 months. So simultaneously, they should put it for ethics. And ethics may come up with some review or some changes, etc. So practically, the first 6 months are going to go in getting your ethical approval. But even if you're waiting for ethical approval, you can start making the other things available. So for example, you will not start your study procedures, but anything you require, your designing of a performer, all that you can start keeping ready. And sometimes there are some studies where you say you're saying primary congenital glaucoma, you can start noting down the UHIDs or the contact information of the patients. And then when you get the ethics approval, you can start. So from that way, by the time they get their 6 months starting point, they're ready to go. And then they often then in the middle, they get very busy with their other work, etc. So they have to keep a kind of a timeline. And one last thing I will say, that things can be changed in between. So don't wait till the end and then go to your guide at the end and then be stuck that I don't have the cases, etc. So keep interacting with your guide, and you can always ask for modifications of a thesis. Supposing you had to put 50 patients or 100 patients, and all of a sudden you find that you're not getting the patients, you're getting, you have put too strict inclusion criteria. Then you may like to expand the inclusion criteria, or you may like to reduce the cases. So these kind of things are also possible, but don't leave it till the end. You can consider, doing course correction during the time of your thesis work.
Thank you, ma'am. Thank you. So after knowing all the things, means how to formulate a research question and what design we can select, next most important thing is what will be our sample size and what are the statistical tools by which we can find out whether our study is effective, our study effectiveness are statistically significant or not. For that, I would like to invite Dr. Ronnie George, sir. Sir, please. Sir will going to give us tips and practical tips for the how to calculate a sample size and what are the statistical consideration which is important for a thesis. Sir, please.
Thank you, Dr. Deepak. I hope I'm audible.
Yes, sir. You're audible and screen is visible too.
Thank you. So I'm just going to talk to you a little bit about the basics of sample size calculation. I'm not going to go into the great mathematics of it, but I'm just going to tell you the basic principles and also touch upon the importance of biostatistical support when you're planning your thesis. So suppose I put up this question for you and say that between a rabbit and an elephant, if you want to pick up whether their weights are statistically significantly different, do you require few, some, or many animals in each group? I'm sure all of you will come up and say few. And why do you do this? You do this because rabbits are generally light and elephants are generally heavy. And you know that the difference is large. And how do you know that this difference is large? You know it from past experience. So even with the variability within different animal species, you know that there is no overlap between these two groups. And with very few groups, you'll be able to pick up a statistically significant difference. But suppose I modify the question and ask you how many elephants of each subspecies will you need to weigh to find a statistically significant difference in weights? And again, ask you to classify this difference as few, some, or many. Most of you will probably say some. And the reason for that is because, as I showed you here, the weights in all these three categories, they overlap a little bit. We know that the difference between them is not small, but it is not as large as in the previous example. And that also you know from previous experience, because all of us have learned that African elephants are bigger than Indian elephants. So basically, you use your past knowledge and you use your gut feeling about many situations in real life to make sample size calculations. The same principles apply to the way that you calculate sample size in medicine. And what information do we use? The same thing that we use for the last two examples. We try and figure out what is the difference between the two groups that we expect. We try and look at the variability within the groups that we expect. For example, if the variability is more, then we may require more patients. If the variability is less, we probably require less samples in each group. And how do you measure the variability within groups? All of us know that when you look at a mean, the variability for a mean is given by the standard deviation or the variance. We are all familiar with it. For a percentage, it's a little different. And for a percentage, for example, suppose you want to look at the variability for a percentage, you have P, proportion of people who have a problem, and Q, proportion of people that do not have a problem. And the variability is basically P into Q. Suppose I ask all the postgraduates attending this session, are you feeling sleepy? And these are the three possible solutions possible. 50% say they're feeling sleepy. In another group, 30% say they're feeling sleepy. And another group, 10% say they're feeling sleepy. So the variability is basically 50 into 50, or 0.3 into 0.7, or 0.1 into 0.9. And you'll see that the variability is maximum in the 50-50 group because half the people don't agree with the other half. So you need to be able to calculate the variability for each study question that you have. And it's very easy to do. And you're all familiar with the concept of a standard deviation. And now with the proportion, all you need to look at is the product of P and Q. What more do you need to do? The next thing that you need to figure out is how much of a difference you want to detect. And the third thing is how sure of the result do you want to be. So these are the other two things that most of you will need to identify as students. So how much difference do we actually want to detect? And the important thing is that it should be a clinically meaningful difference. For example, if you want to assess the intraocular pressure lowering effect of a new drug, you would look at at least 50% reduction in pressure would be the minimum that you consider clinically relevant. Anything less than that is not likely to be of great relevance to anyone. And how do you figure out what this difference should be? You can look at the published literature, and you can also speak to the experts or your guides to try and figure out what is a clinically meaningful difference, because within 1 month of joining your post-graduation, you are unlikely to have the domain knowledge to make this decision. How sure of the result do you want to be? And this in many ways is the easiest question, because you are trying to pick up a statistically significant difference. And by convention, for most studies, you would be using a type 1 error of 5% and a type 2 error of 20%. With very, very few exceptions, this is going to hold you in good stead. So when you look at your sample size measurement, you have identified your research questions as suggested by Dr. Santosh. You have decided your study design as suggested by Dr. Vanati. It's important to define your primary outcome measure, which is what is the factor that you are most interested in your study. And for the primary outcome measure, how much of a difference do you want to be able to detect? And then you need to figure out what is the between group and within group variability. And where do you find this? For the elephant and the rabbit example, you already knew what was going on. In medicine, you may not know what is going on. So you go back and look at the published literature and see what the published literature tells you about the variability within groups. If there is no published literature, you may need to actually do a small pilot study to get this information. And Dr. Alok will be speaking briefly about pilot studies after this. And how sure of the result do you want to be? That's easy. We have already decided that we want a type 1 error of 5% and a type 2 error of 20%. So I'm going to give you a couple of examples. The first example I'm going to give you, suppose your study question is, has the awareness regarding glaucoma improved in a South Indian population? So your primary outcome measure here is the proportion of people who know about glaucoma in a South Indian population. And the design is a cross-sectional survey because you're just going to ask people whether they know about glaucoma or not. and you want to know what is the existing data on this, and you look back, and there's this paper in the Indian Journal of Ophthalmology which has looked at it and has found that 13.5% of people were aware of glaucoma. You plug this into the formula for sample size calculation for a proportion, which looks like this, where n is the sample size, z is the standard error, p is the estimated percent in the population, and q is 100 minus p, and e is the acceptable sample error. So p we already know is 13.5 from the previous literature. Q is 1 minus p, or 86.5%. How close to the truth do I want to be? And this is what you need to decide. Let's say that we want to be within 3% of the actual result. And this is an estimate that you need to do. If you're very strict about it, if you say you want to be within 1% of the expected result, your sample size is going to become very big. If you want to be within 10% of the expected result, your sample size will decrease. And how sure do I want to be statistically? 95%. So this is this stuff you put into the formula, and what you get is a sample size of 499. So you need to do a survey of approximately 500 people in order to get this result. And you can then take a decision as to whether this is feasible or not. What if you want to compare means? If you want to compare, let's say, mean intraocular pressure between two different groups, then this is the formula that you use: Z alpha by 2 plus Z beta whole square into 2 into standard deviation square divided by D square. Don't worry about the formula. It is not something that you are expected to know. It is something that you're going to need to consult your statistician. Your importance is the standard deviation square, for which you will need to figure out a paper to get, from which you will get the pooled population variance. And D is the minimum detectable difference. That is the difference that you want to be able to detect. These are the two things that you as a student have to be able to decide on. I'm giving you another example here, and this is induced astigmatism following cataract surgery, phaco versus manual SICs. This is what you want to measure. Your outcome measure is the difference in induced astigmatism in diopters. And for the pooled variance, again, you don't know what it is off the top of your head. You need to look at the literature, and you will pull up this paper published some years back, which looked at surgically induced astigmatism. And in table 3 there, you find that the mean surgically induced astigmatism in the SICs group was 1.1 with a standard deviation of 0.95. And the phaco group was 0.77 with a standard deviation of 0.65. And this is the information that you need to be able to provide to your statistician so that you can decide how you're going to go ahead with it. What difference do you want to detect here? You can decide whether 0.5 diopters or 0.75 diopters between the two groups is reasonable. Let's assume you go with 0.5 diopters, and then you plug all this into the formula, and what you get is approximately 35 in each group. But don't forget that this is a study which has followed. You're going to include patients, and then you're going to follow them up, and you're going to try and see at 3 weeks or 4 weeks, whatever happened to them. So some of those patients are not going to come to you for follow-up, and you have to be able to account for dropout. And typically, we account for a dropout of 10 to 20%. So you'll end up from approximately 42 patients in eyes in each group. So now, once you have decided this, you need to again take a call. Is the sample size feasible? Will I get enough patients meeting my inclusion and exclusion criteria? Will I get adequate follow-up? And do I have adequate resources to do the study? And that's a decision you need to make once your sample size is calculated. How will you write this in your thesis protocol? It's written very simply. The sample size was 42 in each group, calculated to detect a difference of 0.5 diopters between the two groups with a type 1 error of 0.05 and a power of 80%, and anticipating a dropout of 20%. So this is what you would need to write in your thesis protocol, and you would need to reference the paper that you used to detect that you used to do the calculation, and also reference the paper from which you took the formula that was used to do the sample size calculation. Coming to just a couple of slides on the importance of biostatistical support in thesis planning. It's very important for sample size calculation because they can help you with the appropriate formula that you need to use, and they can guide you to which are the appropriate studies that you could use to get this information. When it comes to data entry, please don't do data entry on pencil like this. Those days are long gone. Excel, numbers, Google Sheets are your friend. Use them to do the data entry. And always show your data entry sheet to your statistician, because the statistician can help you to catch errors in data entry early. Sometimes you're doing the entry itself wrong, and this can help avoid data entry at a later date. That little example that I showed you now is actually quite wrong, because when you look at the first column there, you can never enter you can never analyze data which is 1, 3, 7. You have to have only one number in each cell. If you put date in 3 different formats, Excel is going to do things completely differently with each format. And if you look at the macro, and if you look at these 2 numbers which are marked in left in the right column, that's because Excel has put these 2 numbers as text and not as numbers, and they will be analyzed accordingly. And you should be careful that you don't make these errors when you're starting your data entry. To summarize, sample size assessment is an important part of your thesis protocol. You need to have a clear identification of your primary outcome, a good literature review, and use the biostatistician to help you identify the appropriate sample formula. And at the end of it, make sure that your study is feasible from other viewpoints before you go ahead and start it. Thank you.
Thank you, sir, for summarizing in such a way that anyone can understand, and now our PGs will be highly benefited from it. Dr. Sumit, sir, most of the time what we can see in the practical is that at the time of beginning, the candidates forget to meet the statistician, and at the time of end or the middle, they are running here and there, what we can do and what we can do, what we cannot do. So your tip on them, how they can start from the basic, or what they can plan at the time of their protocol writing and meet the statistician. Your comments on that.
Sir, I would say that most of the students are extremely afraid and confused while perusing their thesis. So I would like to tell them that whenever you get into a post-graduation program, the first thing one should learn is Microsoft Excel. Learn from your friends in community medicine about EpiInfo. That's a free software tool by WHO. Go back and read the chapter of biostatistics on PARC, or the high yield biostatistics book by USMLE. That's high yield biostatistics, or your Mahajan. They were the textbooks. Okay. So because these subjects were grossly ignored in MBBS and will be your backbone for the next 3 years and your further journey into research in your post-graduation program. Also, sample size calculations, sir, I see as a very important tool is that although you may be able to complete your thesis, but when it will come to converting into a high quality publication, many people lose that because at that time they did not meet the sample size, and hence the power of the study goes down, and that becomes as a limitation while you are submitting your thesis, or a cause of rejection from a good journal. You may still be able to publish it in a predatory journal, but then a good work that you had done, but because you missed out on the adequate sample size, will take away that peak of reaching a good journal like an American Journal of Ophthalmology or a British Journal of Ophthalmology. So that is what I will say, not be afraid. Like this was a presentation very beautifully summarized, and I think one of the good easy ways of free sample size calculation would be the Cleveland clinical size calculator. They can access that and keep in touch with their friends who have taken post-graduation in community medicine, sir.
Thank you, sir, for the tips. Our next talk is on the pilot study. Basically, the pilot study is the small miniature of any study which the students can go, or the researcher can go and do, means plan how they can have. I would like to invite Dr. Alok Sen for that. Dr. Alok, please.
Yeah, good evening. I hope my slides are visible and I am audible.
Yes, yes.
So thank you so much for this opportunity, Dr. Deepak, but you have made my task very difficult as I have to present after 3 researchers par excellence. So it's a difficult task for me to be presenting after them. But they have already made my job a little easy because they have already touched upon the topic in their own talks itself. So my talk is on pilot studies. And so before I start, I just want to share a trivia with the postgraduates about Dr. James Lind, who is one of the pioneers of control trials. And he did the first documented control trial way back in the 18th century, which led to the finding of a treatment for scurvy. So that is what is the landmark in the history of research as far as medicine is concerned. Over the years, we have seen a huge numbers of clinical trials across the world. You can see that in 2024, the registered clinical trials are more than nearly 100,000. So, but what is important to know that many of these research efforts, they go wasted because, as has already been mentioned in her talk on design, because of the inappropriate design or an incorrect research question. And this is what is important. You know, there is a saying in Africa that you don't test the depth of a river with both feet, and otherwise you have a fear of drowning. Similarly, it is not good to venture into a research without a good planning. So it is better to do a feasibility study before you embark on a larger study as you would like to do. So pilot study basically, as you would now have realized, is a dress rehearsal sort of before you go in and do the actual study. So it's a small scale test of the methods and procedures that is to be used in a larger scale. So one differentiation between pilot study and a full-scale study is that the pilot study aims to test the feasibility, and this has been highlighted by the previous speakers as well, while a full-scale study the aim is to test the research hypothesis. So the question in pilot study is, can we or I do this? While in a full-scale study, the question is, will this work? So what does it do? What it does is, the information that we gather through a pilot study helps us in refining the various steps or processes in the clinical study or larger study that we plan. For example, as we all know, one of the biggest challenges in any study is to have a good recruitment of participants in a study. And so the question in a feasibility trial would be, can I recruit my target population? So, and the objectives would be like the number of participants that can be screened in a month, or the participants that can be enrolled, average time that is taken to enroll, and what are the screen failures. So if you see that this is a research paper which is on 15 randomized studies from a oncology department, and they found that majority of the screen failures were because the patients were not meeting the eligibility criteria. So if you can change or make the eligibility criteria more inclusive than restrictive, probably you may land up recruiting more patients. So this is how you try to find out where the problem is in the process of the study. Similarly, not only recruitment, retention can also be a challenge. And most of the studies have shown that those who fail, that there is about 30% dropouts in the patients who have been recruited in a study. And so in a pilot study, what you can do is you can find out the retention rates as well as the reasons for dropout. So that will help you in modifying or improving the retention in the actual study. So the other thing that you can do is you can modify your research tool. For example, in qualitative studies like questionnaire-based studies or surveys, what you generally do is use a questionnaire or a survey. And you need to know whether this tool or this instrument is would work in the population that you want to study. So what you generally do is you test the questionnaire and validate this in a pilot study in a small group of patients from the population that you want to study. So this also can be part of a pilot study before you do a long-term study. Similarly, you want to know what are the resources required for a large scale study? Like what would be the budget requirement? What instruments I would be or equipments I would be needing? What is the time frame that is required to complete the recruitment? What are the softwares required to enter the data? And what amount of investigator time is required in a study? Similarly, you would also want to know how much training is required during the research to the personnel who would be doing the research, what kind of data collection would be done and how the data safety could be managed, what are the data variability. For example, we recently were part of this DRMS study group where we are trying to look at the gut microbiome changes in people with diabetic retinopathy in India. And in this study, what we did was we did a preliminary study or a pilot study on 100 eyes. The actual study is on 100 patients. The actual study is on 500 patients. And during this study, we tried to have multiple training sessions across 17 sites. And this included how do we do a clinical examination, how is the fundus photography is to be done, how the stool collection is to be done, and whether these things are giving us appropriate results or not. Another thing that can be tested in a pilot study is the scientific aspect of the research. And this can be safety of the intervention, what are the estimated effect size, and this has been touched upon by Ronnie George sir as well, which can help us in calculating the sample size of the larger study in case you don't have a study that has been done in the past. So here is a study which was done way back in 1996, where they looked into the effect of laser treatment or grid laser treatment on the outcomes of subfoveal choroidal neovascularization. This was before we had anti-VEGFs, and they found that actually in the pilot study, they found that laser is not beneficial, but possibly harmful to the patient than observation. And the actual study was never conducted. So this is how a pilot study can help in deciding whether the actual study needs to be done or not. So how do we conduct a pilot study? First of all, as has already been emphasized, you have to have clearly defined aims and objectives. The study design and the inclusion criteria, as well as the recruitment of participants and data collection, should be as similar to the main study so that you can find out where are the bottlenecks. And finally, you get a feedback from the pilot study. So what a brief on the sample size. Actually, in a pilot study, you may not be required to calculate a sample size, but the sample has to be a representative of the target population, and it has to be large enough to provide a meaningful conclusion. So that is important, but generally speaking, you start with a very small sample. Mostly it is recommended to have at least 30 participants in a pilot study. Now, when you report a pilot study, the reporting is mainly descriptive and not analytic, and the emphasis is not on hypothesis testing. So you are not saying whether your intervention is working or not. But what you conclude is whether you need to stop the main study, as the main study would not be feasible as per your pilot study, or you need to modify some of the aspects of the main study. For example, the protocols, you may want to tweak the inclusion or exclusion criteria, or you may, as Radhika ma'am said, you may want to change the duration of follow-up so that you can have more retention. Or you may, the pilot study may conclude that you can do the large-scale study without much of change. So this is an example which I found out while I was doing literature review on pilot study, and this is a pilot study on different regimen that can be used for age-related macular degeneration, neovascular age-related macular degeneration. And you can see that the aim is to provide feasibility and not on outcome of the treatment. The primary objective is to look at recruitment rates, screen failures, So these are the things that the pilot study is looking at and not on hypothesis testing. The result is screen failure can be a major hurdle in recruitment, and the study recommended that three protocol amendments to facilitate recruitment. So this is how the pilot study is reported, and the conclusion was that the current study protocol is possible, deliverable in a larger scale with some minor changes. So this is how the pilot study is usually reported. So to conclude, pilot study is vital component of research and assesses the feasibility of a large-scale study and enhances its likelihood of success. But most important is that we need to try and publish these results, because when I was doing literature review on pilot study, I found very few articles that had published the pilot study details. Thank you so much.
Thank you, Dr. Alok, for such a good conclusion, and you have guided us how to conduct a pilot study and how to plan. Anua ma'am, one of the important thing in this, whatever the study we plan, is the dropout. So what is your tips on how to manage dropout or how to prevent dropout from the enrollment?
Yeah, thank you, Dr. Deepak. First of all, I would like to congratulate all the speakers. It was so knowledgeable. This session was excellent. Dr. Alok, I think I really like the way the pilot study, like you showed how it improves the design of the future survey. So I think what is important is from thesis perspective in particular, if somebody is doing a pilot study, as you said, it's very, very important to take it to publication, because that is the entire point. The point is that a survey should follow a pilot study. Secondly, I think when it comes to dropouts, I have one point here. So when it comes to pilot studies, maybe it's a possibility that you might have to amend your protocol as the time goes. And it's a possibility, like you showed one study where the effect was actually harmful. So you may even have to abort the study or declare that the final study cannot be done. So I think pilot exploration is very interesting, but thesis perspective, whether it can be done or cannot be done, is something which needs to be thought before you start something like this, because from thesis perspective, sometimes outcome is very important. And what if, what you start as an exploration may not end up with an outcome. And secondly, protocol may be required to be changed as the student is going on exploring the pilot or the dropouts, like Dr. Deepak said. And managing the dropouts, well, I think from thesis, this is for the residents. I know when I did my thesis, I used to have phone numbers of all the patients who were part of my thesis. In fact, my thesis was a pilot study. So I know how difficult it was, because, when you have to tell the patients that you are doing something which has not been done, it is not easy to even take a consent. So it is something which is very, very difficult, but the numbers are usually smaller, so it is doable. And the other thing that I would say about pilot is, like, you showed some excellent pilot studies which were randomized as well. So it's not like pilot studies will lack power, pilot studies will not be good. These studies are novel explorations and should ideally be done before taking up a larger research question. So these are the 2 pearls from me. Thank you.
Thank you, ma'am. Professor Sandeep sir, your tip on how a candidate can proceed, means if they are trying to start their thesis, what are the 2, 3, or 4 points from your side, a guiding point for them they should follow during their whole of the thesis writing journey?
I think from my perspective, I think the first would be from the student side. The student has to know that what his mentor or guide wants to do for a thesis. Now, for example, if many times the student will not be allowed to choose a subject, he often gets the guide. And suppose that person is a retina guy or a cornea guy. So the chances are that he will do a retina thesis or a cornea thesis or so on. So I think the guide and the student have to be on board together that what they want to do. So that is the foremost. Then the feasibility, as I discussed, that many centers have a different capacity, different type of instrumentation. So whether the work is feasible or not. Another very important point which I feel is that if one is doing a type of study which fits into a clinical trial kind of thing, so then we should get that clinical trial registry of India done. Because many a times the journals will ask for a clinical trial registry. So it is always better to get them done ahead of time. And then sample size calculation is extremely important, because I think majority of papers I review for the journals lack a sample size calculation. So they have done a study on 50 or 100 cases, but they have not calculated the sample size. So then the whole study becomes questionable whether the sample size was not done. So there is a bias in the study, or the statistics is reliable, or it is questionable. So I feel all these things have to be taken into consideration. And then lastly, timeline is very important, that don't go up to the last month, because last few months have to be taken for thesis writing also, for the statistical workup, etc. So that kind of a timeline has to be drawn with the thesis guide, when to really finish off the thesis and then do the statistics and the writing work of the thesis. Yeah, I think.
Thank you, sir.
those are the things.
Yes, sir. Lovely. Professor Radhika ma'am, not only the mentee or the candidate is doing their thesis first time, there are a lot of young faculties watching, means they are getting the candidate first time. So what is your tips, how they can nurture their candidate, or how they can maintain a good mentor and mentee relationship, or help them in the thesis part of it, or any research on it? Tips for the mentor, ma'am.
Yes. So it's very important that you should be sensitive to the fact that the mentee is going to be going through a lot of sort of a challenging situation. I can say that they have been, provided a thing that they have to do the thesis, and they've already gotten to the PG, and they're in a very challenged situation, handling so many new sort of experiences all together. So it can be overwhelming. So I would say that you should first have a little bit of a frank discussion, sit down with the candidate. Don't immediately, you have to give it a 15-20 minutes time, one-on-one, and talk to the candidate and say, like, you can discuss various aspects. And even if, supposing you are yourself as a retina or glaucoma or cornea specialist, and you are interested in giving, you have a research idea of your own that you would like to give, still you should have engage the student in the discussion, because if that person is very passionate, say, about cataract, and you're a glaucoma person, then you can look, there are many ways of combining the two. So you should always give some opportunity to the candidate to at least talk and engage, and then see how to find the best topic. Of course, the younger faculty may sometimes be better than the older faculty, because they are fresh, and they may have, they're not, for them it's like a very big thing. So that is not necessarily that they will be finding it difficult, but they should be sensitive about these things, that they should not be too enthusiastic and try to burden the candidate with the too difficult and a too sort of extensive idea, which maybe the person will not be able to manage. So you always have to keep a plan B, plan C. Look, it may be an excellent idea, and maybe it will be successful, but see what will be the feasibility. So start with a brilliant idea. If you have, certainly go for it, but make sure that it remains grounded and practically feasible. Then the other point about the for a person who's starting is the students also they may have, unless you get them engaged in it. So you have to firstly make it very clear that the thesis is an integral and a mandatory part of your MD MS ophthalmology. So it's an extremely important thing. So to the extent that if supposing you're unlucky and your thesis at the end, it rarely happens, but supposing it happens at the end that it is rejected, or for some reason it comes with negative comments at the end, then you have to redo it. So it has to be taken seriously. And it's best that they should know right from the beginning, be prepared that this is a very serious part of your work and it is necessary. You've decided to do an MD/MS ophthalmology, and it is necessary that you have to learn the research methodology. So the more you enjoy it and do it in the proper way, the better it is for you. And also make it clear to them that don't hesitate to give your feedbacks. For example, they may even ask their friends, etc., and they may tell them कि ये बहुत मुश्किल होगा या ऐसे cases नहीं देखेंगे. Encourage them कि आप बोलो, बताओ आपके क्या concerns है, so that together you can come together. You can come at a solution. So I would again say that for the newer ones, don't be worried. I'm sure your thesis candidate will do fine, but be sensitive about these things and plan properly. And also when you're talking to the student, not all students are the same. Some people are a little slow or they are finding it difficult. So then don't give that person a very tough thesis. Try to balance it, because after all, they have to learn the methodology, how to make a study question, how to do a research work. It's it's part of your training. So you may have to adjust accordingly. Yeah.
Thank you, ma'am. Sumit sir, when any student started writing his thesis or the protocol, then the next expectation from a guide is he or she can write a review article on his topic, because they have to write again a big portion of the thesis is review of literature. So what is your tips, means how they can write a review article so that when ma'am accept it without any changes or anything? Sir, you are muted, Sumit sir.
Sir, so
Kindly
thank you, sir. Sir, my submission would be that first of all, you should have the student should acquire a basic knowledge about the topic. And the way I have learned it from my colleagues and my teachers, which I still do, the best way to learn is to type the keywords of that topic on PubMed and try to find out all the articles, pertinent articles related to that topic. For example, the way I learned to read about polypoidal choroidovasculopathy, or the way I learned the treatment of diabetic macular edema. So I wrote steroids, diabetic macular edema, and I went to the oldest article. So it was there that I learned that how steroids, which actually exacerbate diabetes, became the treatment of a complication of diabetes, and the reason was that somebody found that it was actually an ischemic inflammation, and how Jonas in 2001 injected. So I think that is a beautiful way of learning that I have possibly learned it from my teachers and my friends, that you type in the keywords, you go onto the last article, the oldest article, and everything starts from a case report, a series, and then eventually, a case control study and a randomized trial. And this becomes a story. Once you are able to build up this narrative in your mind that how did this condition or its treatment evolved. So then you're able to write a review article, which is, becomes interesting for the readers, and at the same time is able to explain the coming generations that how actually we arrived at this, treatment strategy or, facts. So that is my point. Sir, you are muted, I suppose, or something.
Sir, Anuva ma'am, you are from one of the previous institution, and you have a lot of candidates as DNB and fellows. So what is the role of timeline in doing any research as your point of view?
Yeah, so I think thesis comes with a timeline, which Dr. Radhika was also referring to, ma'am was referring to. But I personally feel that things like thesis are like meditation, and they should actually not have a timeline. So I think that an ideal research should not have time constraints. But as we were discussing about pilot studies also, I think there are certain things which have to come out at a certain time in the society for it to actually have an effect and for it to actually lead to further research. So while some of the residents can think that, there is a timeline and why should there be a timeline, there are certain things which are needed to come out at a certain time. So suppose today I'm saying I want to study about 3D corneas, and tomorrow and years I spend on the same study and do not actually come out with something, then it's of no use. So I think timeline from that perspective should be taken positively, and that your results are going to make a difference. So your results should come out into the world, and that's why I think timeline should be there.
Thank you, ma'am. So I think we are at the end of this CME session and the webinar. So personally, from the team of AIOS ARC, I would like to thank all our esteemed speakers and panelists. Thank you everyone for helping us. And for the viewers, those who missed, they can watch it on the AIOS channel. It is already live and recorded everywhere. Thank you, sir. Thank you, ma'am. Thank you, everyone.
Thank you. Good night.
Thank you and good night.